Hi guys, in this video we're going to be discussing about hypertension and we're going to be talking about systemic hypertension, definition, types, classifications, etiology, and the relevant pathological and clinical findings. And we're also going to be discussing about pulmonary hypertension, again, the definition, types, classifications, etiology, and pathological and clinical findings. We will not be discussing about portal hypertension as that is already covered in a different video called the circulatory disorders of the liver. Moving on, systemic hypertension. Now, it's defined as the increase in blood pressure greater than 139 by 89 millimeters of mercury. You can also say greater than or equal to 140 by 90, but in the pathophysiology books, this is the value given, and it's good to know the value exactly, especially for the pathophysics exam. For patho, it's fine whether you say 139 or 140 is not going to make a difference because of 1 millimeters of mercury, but this is what is technically accepted. Can be of two types, primary and secondary hypertension. Now, primary hypertension is the most common type of hypertension. It is 95% of cases. It's idiopathic, so basically means the exact pathophysiological mechanisms of how it arises are not fully understood. Uh, but there are risk factors which have been identified, and there are multiple risk factors, which include age, genetics, obesity, stress, lack of exercise, and high sodium diets. For age, as you age, with age, you also have these changes that occur within the blood vessels that can give rise to hypertension. Genetics, basically, whether your parents had hypertension or not, also influences if you were going to have it. Obesity, because of multiple factors in obesity, stress. In chronic stress, what you have is the release of epinephrine, norepinephrine, which basically will increase blood pressure, lack of exercise, the body is not adapted, and high sodium diets. And there's basically a long pathophysiological explanation for why high sodium diets uh, can cause hypertension. Now, what happens is in primary hypertension, there's untreatable because there's no pathophysiological mechanism. However, it's controllable. With medication, it can be controlled. Whereas secondary hypertension is on around 5% of all cases, and it arises because it is secondary to some other pathology. Yeah, and if you treat that pathology, you will also effectively treat the secondary hypertension that arises because of it. Now, the common pathologies that it might arise in include renovascular disorders, basically renal artery stenosis. So, what happens in renal artery stenosis is, for whatever reason, there is stenosis that causes decreased perfusion. This decreased perfusion will also lead to decreased net filtration in the glomerulus. And what happens is that there will be a disturbance in the amount of sodium getting filtered. And if you guys remember from physiology, the part of the kidney which is responsible for detecting sodium, although the mechanism is not completely understood, is the macular densa. And when it detects that there is a disturbance in the sodium levels, it's going to secrete renin. And then the entire renin, angiotensin, aldosterone, and aldosterone angiotensin pathway is going to be activated. What happens is renin is secreted, goes to the liver. Liver causes the liver to produce angiotensin 1, and that circulates mainly in the liver and kidneys. You have sorry, not in the liver, in the lungs and kidneys. You have ACE, which is an angiotensin converting enzyme, converts it to angiotensin 2. And what angiotensin 2 does is two things. It is a vasoconstrictor, so it basically increases the total peripheral resistance That causes an increase in blood pressure, and it also causes secretion or promote secretion of aldosterone. But and aldosterone is a hormone governing uh, sodium and water. So what happens is that it causes the desorption of sodium in the kidneys, and also with sodium you have water that gets held on backwards into the body, and both and increased water increases the amount of fluid in the in your blood, and that also increases blood pressure. So that's one way how you can get secondary hypertension because of renovascular disorders. Then you can also have parenchymal disorders such as polycystic kidney disease or diabetic nephropathy. Again, uh, each of them have their own mechanisms. So for basically PKD, because of these cysts can compress against the blood vessels, and compression will lead to decreased perfusion. And again, similarly, RAS gets activated, and in diabetic nephropathy, what happens is that you have these Kimmel-Shield-Wilson nodules that are there produced, and then the arterioles are also made smaller, basically because of the compression. So what happens is again decreased decreased filtration and then RAS activation. And then apart from that, the other common causes of secondary hypertension include endocrine disorders and tumors. So basically, hyperaldosteronism, Cushing's, and pheochromocytoma. So in hyperaldosteronism, what happens is basically you have increased production and secretion of aldosterone. Increased aldosterone does, as mentioned earlier, increases sodium resorption, and with sodium you also have water. But at the same time, it also has increases loss of both potassium and hydrogen ions. So in that, apart from you seeing hypertension because of the increased sodium and water retention, so the increased fluid volume in blood will increase the blood pressure, and you also get loss of potassium, which is also dangerous, can give rise to arrhythmias. Then pheochromocytoma, similarly also the similar mechanisms in Cushing's. And what happens there is it has to do with cortisol, and when you have production of increased production of cortisol increases the sensitivity of the receptors to epinephrine and norepinephrine, so that can give rise to hypertension. Pheochromocytoma, it is adrenal medullary tumor, or not tumor, it's a cancer, neuroendocrine tumor, basically. And what happens in that is you get episodic release of norepinephrine and epinephrine, basically, and that causes you to get uh, acute episodes of elevated blood pressure. And that could be, and that is also termed as acute hypertensive crisis or malignant hypertension. And if you treat the pheochromocytoma, you're going to treat the hypertension as well. Moving on now, classification. It's further classified as benign or malignant hypertension. Now, benign hypertension is your blood pressure is between 139 and 159 for systolic, and 89 and 119 millimeters of mercury for diastolic. This is the technically correct values. However, you can say it's between 140 and 160 and 90 and 120. It will be still acceptable. It's clinically silent, but damage accumulates over time. And the elevated blood pressure leads to endothelial damage, causing extravasation of plasma proteins, matrix deposition, leading to luminal narrowing and decreased perfusion. And then you get complications for whatever organ is getting decreased perfusion. But the most common one is atrophy. Morphology in arteries, you get yeah, I actually switched this up by mistake. But what happens is you in arteries you get fibroelastic hyperplasia, and in arterioles you get hyaline arteriolosclerosis. So hyaline arteriolosclerosis, this was also covered in the arteriosclerosis and atherosclerosis video. But basically, because of this increased blood pressure, uh, you have extravasation of the plasma proteins and they start depositing in the vessels, and that's why it is hyaline arteriosclerosis. And as for arteries, what happens is fibroelastic hyperplasia, and it is the growth and proliferation of fibrous and elastic tissue in response to these increased blood pressures. And when they increase the thickness of basically the tunica media, where you get most of your fibrous and elastic tissue is present, what happens is that it comes as a consequence of luminal narrowing. So it's not that with the size of the vessel wall, there's also increase in the lumen. It's a compromise where if the luminal thickness has to increase, the wall will decrease in thickness, and vice versa. So in this case, what happens is you have increase in thickness of the wall at a compromise for luminal cross section. And the complications, these are very important to know for the exam. So H, the acronym is heart. So H is for hypertrophy of the heart. So why does the hypertrophy occur? Because of the increased afterload. You get concentric left ventricular hypertrophy to compensate uh, and pump blood against this increased afterload and can develop into left side heart failure. E is for eyes, and what happens in the eyes is hypertensive retinopathy, basically arteriolosclerosis in the blood vessels of the eye. A is for aortic aneurysms and dissections. So increased blood pressure weakens the endothelium, and a weakened endothelium can give rise to aneurysms and dissections. R is for renal failure. So in renal failure, now you got to be very careful because if it affects the afferent arterioles, you will get bilateral atrophy. The afferent ones are the ones before the glomerulus and Bowman's capsule. So decreased perfusion means that there's not going to be enough oxygen and nutrients being delivered to the cells, and if they're going to basically adapt to it by atrophy. And if it is the efferent arterioles that are affected, it causes hyperfiltration injury, and that's also covered in the kidney pathology videos. Now, and T is for stroke if the brain vessels get affected. Now, moving on, we have malignant hypertension. This is characterized by severe elevation in blood pressure over 180 by 120. However, it is short-lived, it is acute. Okay, and it arises generally from pre-existing benign hypertension or from episodes of underlying disorders such as hyperthyroidism, pheochromocytoma, and preeclampsia. Preeclampsia is a pregnancy-related disorder, and more of it about it is also in the female reproductive videos. Now, as I remember, regarding the benign hypertension and malignant hypertension, these terms, however technically correct, are not preferred by some professors. So instead of using benign hypertension, it is actually preferred if you use chronic hypertension. And instead of malignant hypertension, the professors would prefer that you use acute hypertensive crisis. So do remember this for the exam. Now moving on, for the morphology, in arteries you get mucoid intimal hyperplasia. So basically, it is the swelling of the intimal layer of the arteries in response to this malignant hypertension. And for arterioles, you get hyperplastic arteriolosclerosis and fibrinoid necrosis. This hyperplastic arteriolosclerosis has a very um, characteristic morphology, and it is basically called onion skin like. So basically, if you were to cut an onion from the center and just hold it up, the layers individually can be seen. That's how the artery would also look in hyperplastic uh, arteriolosclerosis. So just remember, let me just write it down. Onion skin. Bad writing, but hopefully you guys remember onion skin appearance. Now, complications. You get acute renal failure or fleet bleeding kidney due to arterial rupture. So basically, because of this extremely high blood pressure, these smaller arterioles are not strong enough to handle this, and they can rupture. And with their rupture, it causes these small, tiny hemorrhages in the cortex of the kidney, and that's why it's termed as flea-bitten kidney. It can also cause encephalopathy. Basically, if you have any cerebral hemorrhage, rupture of any of the um, vessels in the brain, blurry vision and papillary edema. Basically, because of this increased pressure, you also have increased intracranial pressure, and increased intracranial pressure, what it causes is going to cause uh, excessive fluid uh, loss from the vessel. Basically, increases the rate of filtration in the vessels. So in the eyes, this is very significant because it can cause papillary edema, and that can also lead to blurry vision, and it can cause cardiac failure. Why? Because for even for a small amount of time, if the individual's heart um, is not if the individual's heart is not accommodated, or is not what's the word I'm looking for here, is not adapted. Okay, if the individual's heart is not adapted to withstand such high pressures, blood pressures, such high afterload, then it will lead to cardiac failure immediately, as the left ventricle will not, under any circumstance, be able to generate a sufficient cardiac output or sufficient enough pressure to just get blood from the left ventricle into the aorta. So it can legit just kill the individual immediately. So that was about systemic hypertension. Now moving on to pulmonary hypertension. It's elevated mean pulmonary artery pressure and greater than 25 millimeters of mercury. Um, then you have types which are primary and secondary. So pulmonary hypertension is idiopathic. It's poorer prognosis than secondary. And however, the exact mechanisms to why it occurs are not fully understood, but it has been shown to be associated with BMPR2 gene. Is a bone morphogenetic protein receptor 2 gene. So a mutation in this gene basically causes excessive smooth muscle proliferation, and with that, you also have decreased compliance of the vessels, which can lead to hypertension in primary. Secondary pulmonary hypertension is more common. There are multiple etiologies such as chronic lung diseases, congenital left to right shunts in the heart, left side heart failure, recurring pulmonary embolisms, and all. So how do chronic lung diseases cause pulmonary hypertension? Is by vasoconstriction. So in these lung diseases, you have hypoxia. With hypoxia, the physiological response is vasoconstriction in the blood vessels. Vasoconstriction causes an increase in in resistance, not total peripheral, but resistance. And with an increased resistance, you also have increased blood pressure. For congenital left to right shunts, these are congenital deformities within the heart, and they include ASDs, VSDs, and PDA, patent ductus arteriosus. And what happens in this is, especially if you're considering ASD and VSDs, so they increase the mean pulmonary flow volume and pressures. So if you were to imagine a heart, let me just draw it out. So this would be your right ventricle, and this would be your left ventricle. So what happens is, that's fine. So what happens is that there is either in the ventricle it could be a VSD. So this allows for communication from the left ventricle to the right ventricle. And what happens is that you have increased blood volume in the right ventricle. With increased blood volume, you also have increased blood pressure. And all of this blood is now going to go into the pulmonary circulation. With increased blood volume and pressure in the pulmonary circulation, this is basically going to give rise to hypertension. And uh, and apart from that, as compensation, as a compensatory mechanism, the right ventricle will hypertrophy to overcome the pressures that it's sending itself into the pulmonary circulation. And after some time, what happens is, if it accommodates, there is going to be thickening of the right ventricle. So it's going to become thicker now. This is going to be entire right ventricle wall. And if it is thick enough and it produces the pressure sufficient enough, what happens? It can reverse the shunt and it can flow backward from the right side into the left side. And it's called shunt reversal. That's Eisenmenger syndrome, and more about those is covered in the heart pathology videos. But do know that VSDs and ASDs, if you look at the if I were to draw the atria as well, basically a quick atria. So an ASD is going to allow blood from the left atrium to the right atrium. And this will also increase basically uh, the mean pulmonary blood flow and volume in the outflow tract. So that's how it can lead to secondary pulmonary hypertension. Left side heart failure, how that does it was covered in my video on question 17 and 18 of general pathology, which talks about right side versus left side heart failure. But quick recap is, left side heart failure leads to uh, backup of blood into the peripheral circulation, which is the pulmonary circulation, and congestion of blood in the pulmonary circulation can give rise to pulmonary edema. Long-standing congestion leads to healing by fibrosis, and fibrosis basically causes compresses against these vessels and causes increase in blood pressure by compressing them, because their vessel diameter becomes narrower, and that can lead to pulmonary hypertension. Recurring pulmonary embolisms uh, can also cause secondary pulmonary hypertension. Why? It's basically it causes hypoxia and then again vasoconstriction as as a physiological response mechanism. Morphology, in the arterioles, you see medial layer hypertrophic and intimal fibrosis. So just remember medial hypertrophy. Intimal fibrosis is two terms important for the exam. And this is technically not morphology of the pulmonary hypertension itself, but morphology as a compensation mechanism. You see right ventricular hypertrophy. Complications, it's basically the main one is cor pulmonale. Cor pulmonale basically means that it's right side heart failure due to pulmonary hypertension. No matter what the etiology is, if there's pulmonary hypertension that causes right side heart failure, immediately it's termed cor pulmonale. It can be divided into acute and chronic cor pulmonale, and the morphology does vary depending on whether it's acute or chronic. Because in acute, there's just not enough time for the right ventricle to adapt. There's no time for it to hypertrophy, and the only thing that it can do is dilate. That's why you see right ventricular dilation in acute cor pulmonale and chronic cor pulmonale. There is time to adapt. That's why you see right ventricular hypertrophy. You can also see pulmonary edema because of the increased pressure. It's going to cause increased fluid flow into the lung into the lung tissues. So, and long-standing edema leads to brown indulation. Why? Because over time, as the fluid starts accumulating, you will also have macrophages, and with the fluid, there also can be some red blood cells which can leak into the lungs, and macrophages will go engulf. There's going to be breakdown of hemoglobin. They're going to engulf the iron, and then macrophages, which have engulfed the iron, are referred to as siderophages, and that's why, and they appear brownish, and that's why it gives rise to a brown indulation of the lungs. It can also cause the other complications are atherosclerosis of the pulmonary trunk. Why? Because one of the main risk factors for atherosclerosis is hypertension. So, and it's no different in the pulmonary circulation as well. I mean, that covers all of the main things that were needed to be mentioned about hypertension. It's a very simple, straightforward topic, and good luck in the exam, guys.